Good evening and Assalamu alaikum to everyone. Welcome everyone and thank you for joining us for today's webinar. My name is Dr. Zahid Mia. I am from Pakistan and I'm working as a diabetologist and endocrinologist. I'm the head of the Diabetic Food Department and working as a Vice President of D-Food International and also the chairing the MENA D-Food International. Many thanks, Professor Jamal and Professor Abdul Basit, for giving me this opportunity to moderate today's webinar on advanced painful neuropathy. As dear colleagues, as you know, that diabetic peripheral neuropathy is one of the common microvascular complication and one of the leading cause of diabetic foot ulcer. And although the number may vary, the diabetic painful neuropathy occurs approximately 25 to 30% of the people with diabetes. And more interestingly, about 12% of the patients do not report symptoms, and around 39% of the patients with this problem do not receive any treatment. And as you might remember, Riaz Malik pointed out in previous program on the DPNP is not a priority amongst the physician and the patients in many countries. At present, we are having some more understanding of the pathophysiology and early diagnosis of this problem. But we're still waiting for some breakthrough in the management of DPNP. In today's webinar, our worthy speaker Professor Mohammed Hasnan from UAE, Professor Sam Al-Brabi from UK, and Professor Eric Buscher from Switzerland will enlighten the advanced painful neuropathy. And I'm sure we will all learn more about it in this 2-hour Blue Circle MENA region program. I'm now sharing with you the agenda of the program, and there is a little bit change in the agenda of the program. And you can see over here that the Professor Abdullah Ghamidi is apologized for his personal reason to not participate in this meeting. So we are very sorry about this one. And just a little housekeeping before we get started. If you have any question during the presentation, please type them into question box in your control panel with the speaker name. I will bring them up at the end of the webinar during question and answer session. And now I will invite, it is my great pleasure to invite our first speaker, Professor Mohammed Hasnan, who needs no introduction and a great friend of us and well known for his expertise and vast knowledge. He is the senior consultant in endocrinology and in diabetes at Dubai Hospital, associate director of postgraduate diabetes education, Cardiff University, UK, and he's the chair of diabetes and the Ramadan International Alliance. He has keen interest in clinical and services development activities and the research activities. He is a true educationist. He has the honor to receive first prize for the UK Diabetes Structure Education and EASD Education Program. It's over to you, Professor Mohammed Hasnan.
Assalamu alaikum and good evening, everyone. Thank you very much, Professor Zahid, for the kind introduction. Thanks for Medtronic, our sponsors, for the event for tonight. And indeed, it's my delight to be part of this IDF MENA faculty with eminent speakers that I'm sure everyone will enjoy. We had not long ago as IDF MENA a session on foot, which included some of the discussion on diabetic neuropathy. Tonight, the focus is on the painful part of neuropathy. And indeed, I'm starting with the dilemma we have as diabetologists, managing those with advanced diabetic neuropathy. As our chairman mentioned, diabetic painful neuropathy prevalence is quoted around 21%. A large study of 15,000 persons from northwest of England have shown that it's quite prevalent among people with type 2 diabetes and more prevalent among women as well as patients of South Asian origin. It's very much an underreported problem, as was mentioned by our chairman tonight. And indeed, our very good friends, Professor Riaz Malik and Tara El-Had from Qatar, along with Ponirakis, did publish this information earlier this year, where they looked into the prevalence of diabetic neuropathy. And as you can see here, this is 23% of the population of diabetes in secondary care. It's not all over diabetes, it's secondary care. But when they looked into painful neuropathy, 78% of those with neuropathy had painful neuropathy. And the striking point in their study, which matches what was seen in other studies as well, is that the vast majority of these, 82%, were not recognized. They were diagnosed during the study, which tell us that probably we are all as healthcare professionals are not looking enough for painful neuropathy. What we know from guidelines and what we know from previous publications, that at some stage, probably 10 years on the line after diabetes start, 40 to 50% of people will have some sort of neuropathy. Having pain is a bless, of course, because painless damage to the foot can cause ulceration and lead to amputation. But on the other hand, have excessive pain could be struggling. I come from a family with lots of diabetes. I recall my late mother, rahmatullah alayha, she used to suffer every night with painful neuropathy and spend most of the night not sleeping. So it's very much important that when we are doing the examination, we need to talk to our patient and ask them whether they have pain or not. Of course, doing all the tests is important, but we also need to ask them, as Diabetes UK has pointed us that we must, among all the what we're doing of inspection, of bone testing, the 10-gram monofilament, and all the other tests, is to ask the patient, do you have pain in your feet or not? And that's really quite important. We all know that the tools for detection of neuropathy are pretty simple. They're largely the pinprick, the 10-gram monofilament, and the tuning fork of the 128 kilohertz to assess for neuropathy. And as we can see here, the ADA is advising us to how to test for the painful neuropathy or neuropathy in general, looking into the small fiber function with the pinprick and the temperature sensation, and then looking into the large fiber function through the vibration and the 10-gram monofilament, as well as the protective sensation still with the 10-gram monofilament. So we're talking about very simple, very cheap tools that can help us to detect the foot with neuropathy. Having pain is really quite troublesome to the patient. Usually this is distal symmetrical polyneuropathy. Many would have numbness, tingling, or weakness in the Stockholm gloving distribution. And very frequently, patients with neuropathy, we know that they would have increased ratio of falls because of the neuropathy. Obviously, this could be problematic, and the risk of ulceration and loss of the foot or the leg is quite frequent. Up to 15% of those would develop ulcers and potentially then amputations. It is quite interesting to look into the data that Solomon Tesfaye published 15 years ago in New England Journal of Medicine. And it's quite interesting to see that hypertension carries a pretty high risk for the development of neuropathy, followed by smoking, and then glycemic control. How high the HbA1c is important, and also the sudden changes in HbA1c could trigger neuropathy. Of course, diabetes duration is another very important factor. Then come some of the traditional risk factors for diabetes in general, such as BMI and triglycerides. All of these factors were statistically significant. Total cholesterol increase was not significant. So the classic for advice from Diabetes Canada is we need to prevent the problem, and that's largely with good glycemic control. We screen for it to detect the problem, and then we only have to treat the pain because unfortunately we cannot reverse the process. So it's very much trying to find the underlying cause of the condition. Rarely the cause is not diabetes, and then we need to look into it. So prevention of the problem is quite possible if we detect it early and we address all the components that can make the problem worse, from a social problem, the psychological problem, as well as the biochemical and biometric issues. But then we are left with symptomatic treatment. As I mentioned, unfortunately, we do not yet have treatment that can cure the problem. We just have to improve the physical function, reduce the psychological distress, and improve the overall quality of life. But indeed, it's a dilemma for us. This is a short cut, a screenshot from the ADA guidelines. And as you can see, the guidelines for neuropathy are not major. It's almost for painful neuropathy about half a page. And they do obviously refer that there's a large document that our colleagues, Professor Andrew Bolton, the president of the IDF, as well as our colleague from Qatar and UK and Pakistan, Riaz Malik, is co-authors into this. But when you look into specifically some of the important points, you will find that I have increased this here, and the meaning is glycemic control helps in reducing the incidence, but does not help once a person have painful neuropathy. So those who have good control, they have less incidence of neuropathy in general, whether this with autonomic testing or nerve conduction tests, as in black, those with intensive treatment versus the standard treatment. And that's important for us to remember. But at the end of the day, it's a fact that those with painful neuropathy, two different studies, and on average, moderate to severe pain is there in 70 to 80%. So mild is the gray color, moderate is the blue, and severe is the yellow. And as you can see in these two large studies, the vast majority of the chart that you see is between blue and yellow, which is moderate and severe level of pain. Now, this is not just about pain discomfort, which is there in 93% of those with diabetic painful neuropathy, as compared to the UK general population, which is about a third of this, so 3 times higher, but many other aspects, depression and anxiety, 3 times as well, 60% versus 20%. Limitation to everyday usual activities, 75% compared to 16%. Mobility problems, 80% compared to 8%. So indeed, painful neuropathy could be a serious barrier. This is the impact on the mental and the physical function of a person who has neuropathic pain. Difficulty sleeping, lack of energy, drowsiness, concentration difficulties, depression and anxiety, and poor appetite. So quite a significant cocktail of symptoms that some of them could be quite debilitating for people who are in their middle age and want to function. So no wonder that many people will be spending their night and spending their hours feeling they have the constant hurt and the constant pain. That eventually will affect their mood, will affect their energy level, they will stop doing their usual daily activity, they will not be able to sleep well. That all can affect their concentration at work and their social life as well, and it ends up with not enjoying the life and indeed very reduced quality of life. It's a sad scenario, but we see it all frequently in our daily life. So when we think of treatment, we have to think of how much the treatment will be able to overcome these challenges and barriers. And this is the dilemma that we all face very frequently. So someone with maximum pain will be miserable. Someone with minimum pain or indeed no pain will be far much happier. And the organizations are saying to us that a reduction of 30 to 50% of pain would be a meaningful clinically achievement. So from a patient point of view, we are saying to someone, we are leaving you with 70% of your pain or 50% at best. And we consider it as healthcare professionals that that's a good achievement. I don't know what will be the perception of the patient. I'm sure 50% reduction is an achievement, but certainly they would all would like to have no pain or very minimal pain. And here is what we really need to score and to put on a scale, the pain intensity at baseline, and then we look into the change. And if the change is 50% or more, that's substantial. If it's 30% or more, that's moderate important. But if it's only 10 to 20%, that's minimal important improvement or change. So what does NICE guidelines say to us? Well, it says to us, we need obviously to think of the therapy. We start with Diloxatine, and if contraindicated, we go to oral amitriptyline. It's not really the focus of this session, or at least of my session, to give you the ins and outs of which drug we use and which drug we combine. I'm sure the following speakers will address this largely. But let's not forget about a very important step that many of us do not have available frequently, which is refer the person to a specialist pain service or a condition-specific service. And pain clinics with the right skills and expertise are not frequently available. And let's look into the person with the painful neuropathy. And here is the 50% achievement for response for Pregabalin and Diloxatine. And you will see it's pretty much comparable between the two. So Diloxatine in 2 studies was able to achieve 47-48% in comparison with placebo, and Pregabalin, this was dose-dependent, 47% for the 600 milligrams and 39% for the 300 milligrams. But when we look into the latest recommendation from the document that I've alluded to before, where Professor Bolton and Professor Riaz Malik both are co-authors, of course, they say here, if you're not sure of the source of the pain, refer to neurology or pain clinic. If you're sure of the source of the pain, start treatment. And here are the various treatment options. And then when the pain is not responding, we go to combination or switching therapy, and then maybe adding some opioids. And then finally, when we're stuck, we need to refer to a pain clinic. And that's the issue that we really need to think of, because frequently we don't have these facilities available. For myself, I don't have that facility available in my current practice. So going into the side effects and the improvement of the drugs. So the improvement of the Pregabalin is dose-dependent, of the Diloxatine is not dose-dependent. Tricyclic antidepressants, there is some data that is available and they are helpful, although they don't have the right license. Gabapentin effect is also dose-dependent. And we really need to think of the dose that would achieve the 50% response or close to, rather than the weak response. So typically this is what we're after. And combination drugs or studies have been shown to have little improvement compared to monotherapy, but of course, more studies have been published since then. So an important dilemma for all of us is the side effects of these drugs. Some of them are now even listed in narcotics list, where we can only prescribe with difficulties and provide 1 month at a time. And as you can see, the side effects of Pregabalin are very much dose dependent, and also dizziness, somnolence, peripheral edema, and some of the other minor symptoms are there. More or less, Diloxatine will also have similar side effects. Dizziness and somnolence are there as more of the gastrointestinal side effects with Diloxatine compared to Pregabalin. So when you really think of the side effects of both, here is Diloxatine and here is Pregabalin. For dizziness, more of the Pregabalin. For somnolence, both are equal. For nausea, Diloxatine is a lot more higher. But these are very much the symptoms of the condition itself, the drowsiness, the lack of sleep, and difficulties with concentration. So on one hand, we're trying to treat these problems, and unfortunately, sometimes many of the patients on treatment, let alone, of course, the tricyclic antidepressants, end up with this. So I think the important message from the IDF 2012 is, after we are stuck, or ideally even before it's too late, we need to refer to patients to our expert in pain control. So in conclusion, ladies and gentlemen, painful neuropathy is a common problem that is largely underdiagnosed and undertreated. It has a significant negative impact on our patients, including the quality of life, the biopsychosocial approach to treatment is required. A reduction of pain by 50% is what is considered as meaningful. And about only 50% of the patients can achieve this with the current recommended treatment. Many patients remain with poor control and inability of the medication to control their pain, due either to the poor tolerance of the medication or this is just the efficacy. And after all, we have to think of tools and extra options, and I'm delighted that tonight we'll be having some insights into the role of pain clinic. And with this, I'll leave you with a photo of my beloved city, Alexandria. Thank you all.
Thank you very much, Professor Hasnain, for a really clinical-oriented lecture and talk. It's really clear many things in our participant. And I think without further delay, I will invite Professor Sam Al-Dawi. He is the consultant in pain management, the James Cook University Hospital, Middle Grove, United Kingdom, and he is the Research Network Executive Associate and Medical Technology-led Northeast and North Cumbria, and current chair of the Science and Research Committee of the British Pain Society, and he is the subsection editor for the Journal of Pain Medicine, Journal of American Academy of Pain Medicine. He is the president of the Specialist Interest Group of Neuromodulation at IASP, and he has published more than 100 articles on the subject of pain relief and the cost effectiveness of various pain procedures. Now the scene has been set by the Professor Hasnain for the Sam. Over to you, Sam.
Thank you very much, Dr. Mian. I think it's a very excellent talk by Dr. Hasnain, and much of what I will say will be rehashing of what Dr. Hasnain has already said, but from a different perspective. This is where I work, James Cook University Hospital, and it is set in the in a very nice part of England in the northeast. Here you can see Rosebery Topping, which is one of the highest hills in the area. You can walk up and down in about 2 hours, provided you don't have a neuropathy. I suppose if one has a neuropathy, that would be very difficult. Painful diabetic neuropathy, I would like to start with the basics. I would like to start by defining neuropathic pain. Neuropathic pain is defined by the International Association for the Study of Pain as pain caused by a lesion or disease of the somatosensory nervous system. As we've heard, about 30% to 50% of diabetic neuropathy develop neuropathic pain. Neuropathy itself has a lot other causes, but diabetes is the most biggest cause of neuropathy. The hallmark of diabetic neuropathy when it presents to us in the pain clinics, and indeed when it presents to you, is what we call a spontaneous burning pain. So this is the pain that is not dependent on the patient touching something or putting on socks. The feet burn regardless. There are also what we know as positive sensory symptoms like brush allodynia or pins and needles. Also, most of the patients are, when they present, are in a bit of a dilemma. How come my feet are numb, but they're still painful? And that's quite something for a patient to present to you and give you these two, in their minds, contradictory symptoms, because they most likely think you wouldn't believe them. As you've heard from Dr. Hassanein, moderate to severe pain is present in about 3/4 of these patients. But it's not just about pain, it's about depression, anxiety, sleep problems, and poor quality of life. And as such, when we look at treating people and when we look at measurement of outcomes, we have to measure outcomes for pain as well as all the other accompaniments of pain. And you'll see this in some of the case presentations later on. So if we were to look at the pathophysiology of diabetic neuropathy, the actual cause, the exact cause of pain in diabetic neuropathy isn't very clear. But looking at this diagram of a spinal nerve, you can see the motor neurons in the anterior horn. You can see the body cells of the sensory neurons in the dorsal root ganglia, and a mixed nerve with myelinated and unmyelinated C fibers that carry the pain perception. Largely, the pathophysiology that you see in diabetic neuropathy is about ischemia, demyelination, degeneration, and changes in the Schwann cells, particularly the axon transport. Which bit of this exactly causes the pain remains unclear. So, as we mentioned, as Dr. Hassanein and I mentioned earlier on, we're looking at a condition with many facets. It's not simply pain. There is pain, there is sleep, mood, functional limitation, poor quality of life, progression, and finally foot ulceration. So those are all targets for the treatment of a diabetic neuropathy. So you've seen this algorithm, no doubt, many times. I've taken this from a paper in Nature in 2019, but it's very, very similar to the NICE guidance algorithm that was published a few years ago on neuropathic pain, with the exception of one single small yellow rectangle here. Is we now know that opioid analgesics in the long term should be avoided, that opioids are not an option for long-term pain. As a matter of fact, they may be counterproductive. You've heard about SNRIs like Diloxatine and venlafaxine, gabapentinoids, and tricyclic antidepressant. And the choice of first line of therapy generally nowadays is an SNRI, because the weight of the evidence is stronger than tricyclics, and finally gabapentinoids. And then you either combine them, or you consider a different first line drug if that one doesn't work. Looking at the doses and where you start with these drugs, Dr. Hasnain has told you a lot about the side effects, and I will stress this point in a few minutes again. I mean, with the tricyclics, you may know that there is a difference in side effect profile between the tricyclics. So, for example, amitriptyline is far more sedating than nortriptyline and may be used in a smaller starting dose and may be better employed to induce a peaceful night's sleep, if you like. Diloxatine and venlafaxine have a side effect profile that is similar to gabapentinoids, but perhaps a little bit more. The SAEs are a little bit more common. So, looking at the evidence of where is the evidence strongest for drugs, this is a recent systematic review of many studies, and basically the conclusion, what you want to take home is the strongest evidence is for the SNRIs, diloxatine and venlafaxine. That is followed by pregabalin, oxcarbamazepine, then tricyclic antidepressants, atypical opioids, very low, botulinum toxin, all these more effective than placebo. But you can't make a clear conclusion about whether they affect the quality of life or not. Again, a lot of these studies are less than 6 months, and studies with less than 6 months give you often a very rosy image of what the impact of a medication is. So SNRIs, we've heard a little bit about those from Dr. Hasnain. These have demonstrated efficacy. Again, diloxatine and venlafaxine have reasonable evidence. But again, they can cause adverse events. The adverse events are very similar to gabapentinoids: dizziness, fatigue, nausea, and insomnia. And you've heard that these are the same adverse events of the disease itself. My main interest in this area is gabapentinoids. And this is an article we published recently in the British Medical Journal together with a team from Australia. Looking at the use of gabapentinoids in neuropathic pain. I understand that in the Middle East, as well as in the UK and some of Europe, gabapentinoids are now becoming controlled drugs. There is a very good reason for that. It's about the amount of prescribing that we've seen for gabapentinoids has expanded significantly in the UK in recent years. So let's take a look at what is the impact of gabapentinoids in diabetic neuropathy. So these are the indications, if you like, by country. So it is pregabalin and gabapentin are both licensed for treatment of severe peripheral diabetic neuropathy in the UK. And that is the same in Australia and in the US. Oddly, pregabalin, you'll find that also has indications for fibromyalgia, other types of neuropathic pain like neuropathic pain and spinal cord injury and post-herpetic neuralgia. So this diagram sums up the impact of pregabalin in diabetic neuropathy, defined as 50% pain relief. As Dr. Hasnain mentioned, is 50% pain relief enough? If you ask the patients, probably not. But it is a reasonable starting point. And this diagram shows you clearly out of 100 patients, 41 will experience 50% pain relief from 600 milligrams of pregabalin per day. Looking at the adverse events of these 100 patients, here you can see the blue people, 69% will experience an adverse event. Although most are moderate, only 3 to 4% will experience a serious adverse event. And that yellow person is the odd one that will experience misuse of pregabalin. And we will talk a little bit about addiction and misuse of pregabalin. But overall, the picture conveys to you that those who are not affected here are in the minority. What about gabapentin? the effectiveness, as you can see, that the black ones, those who are not getting an effect, are very much in the majority, and only 38 out of 100 patients will get 50% or more pain relief. How many will get side effects? Again, there are those who are not affected here are very few. There is the odd one who will go on to misuse the drug. There are 3 to 4 who are getting serious adverse events. The majority are getting mild to moderate adverse events, but they're still getting adverse events. So this shows you the number of adverse events and the severity of it. And generally, as we've heard, dizziness and somnolence are the most common adverse events of gabapentin and pregabalin when compared to placebo. What is the reason why gabapentinoids have been classified as controlled drugs and are being reviewed across the world is the incidence of misuse, particularly the misuse of gabapentin, pregabalin in association with misuse of opioids. So when people conducted a population survey of the misuse of pregabalin and gabapentin in the young patients in the UK, the incidence of the lifetime prevalence of misuse of gabapentin and pregabalin is between 1.1% and 0.5% for gabapentin and pregabalin. The gabapentinoid misuse is higher in people with opioid use disorder, and indeed co-prescribing both together is a very high risk of overdose-related deaths. So, in conclusions, gabapentinoids are effective in less than 50% of the patients. I would say probably less than 40% is reasonable. A tenth of those will discontinue the therapy because of an adverse event. A total of pharmacological management is ineffective in a third of patients with diabetic neuropathy. And the question is, why would you refer a patient to the pain clinic? A lot of our colleagues in diabetes ask the question, what else can you offer? You have the patients think that it is very much more of the same, more tablets. That's not necessarily true. We now have a lot of techniques in our armamentarium. This is the vast array of techniques of neuromodulation, which is stimulation of the nervous system using implants or external devices. And a lot of this you'll be familiar with, like deep brain stimulation for essential tremor, Parkinson's disease, cochlear implants for deafness, vagal nerve stimulation for epilepsy and depression. What we want to talk to you about today is spinal cord stimulation for chronic pain. Neuromodulation is a vast field, but we want to concentrate on spinal cord stimulation. What is spinal cord stimulation? It's largely the application of electric current to large diameter fibers in the dorsal spinal cord. So we insert 2 leads in the epidural space, and through these, the current is applied to the dorsal part of the spinal cord. So as you can see the arrangement here, a wire goes in the epidural space through a needle, like the epidural injections that are done during pregnancy, but this is a wire rather than a local anesthetic. And this is attached to a battery that is implanted somewhere into the patient. Very much like the arrangement of a pacemaker, except that it goes into the spinal canal. Here is the device, if you like, and you can see how it generates electrical impulses that stimulate large fibers of the spinal cord. This short animation shows you how a current travels up and down the spinal cord and will stimulate the dorsal column, and will also travel backwards and out of the spinal canal. And that may explain how these devices work. And if I give you a short explanation of the mechanism of action, which is quite a complex story, but the easiest way to understand it is there are two mechanisms or two levels of mechanism of action of spinal cord stimulation. So here you can see a section of the spinal cord. This is the dorsal horn where the sensory circuitry is housed. And here you can see the lead or the wire of spinal cord stimulation that is positioned in the epidural space. Now, a passage of current, as we said, will through that will propagate the current upwards towards the brain, which we call orthodromic stimulation, or with the direction of the fibers, and will propagate the current backwards, which is antidromic stimulation, against the direction of current transmission. So looking at the antidromic stimulation first, or the backwards stimulation, this goes back to the circuitry in the dorsal horn, which contains the inhibitory neurons. Stimulation of the inhibitory neurons produces a dampening of the coming pain signals into the spinal cord. So that reduces the extent of stimulation that is firing continuously from a patient with diabetic neuropathy. Then the second mechanism is orthodromic, and that goes up to the brain, and that is there is a central mechanism that ascends to periaqueductal gray, stimulates the periaqueductal gray, and that in turn produces a descending inhibitory pathway that acts on this circuitry and further inhibits the transmission of pain. I think with that, I will say thank you very much, and I will hand you over to our next speaker. Thank you.
Thank you very much, Sam, for this beautiful lecture, and you stimulated us as well regarding the painful neuropathy. What next to be done in a difficult cases, or in cases where the patient not improve, because the physician and the endocrinologist only can serve the patient up to 50% level. So that's a good opportunity that you have shown to us. Now, without a further delay, I will request Professor Eric Buscher. He is the Senior Consultant, Department of Anesthesia and Intensive Care, Pain Management and Neuromodulation Center, ESC Hospital of Morges, Switzerland. He is the Chairman of the European Diploma of Anesthesia and Intensive Care Examination. He has published more than 100 articles in the area of pain management and neuromodulation in peer-reviewed journals, and also been key author of 6 books and monographs. Over to you, Professor Eric Buscher.
Thank you very much for a very, very nice and friendly introduction. What I'm going to do over the next 20-25 minutes or so is present the evidence of the studies we have today in neuropathic pain, with a particular focus on diabetic neuropathy. So I'm just quickly going back to my disclosures. My department has received funds from the National Swiss Foundation, the Federal Commission for Technology and Innovation, as well as from Medtronic. I have no other financial interest or shares in any company. Now, spinal cord stimulation has been recognized since very long as an effective way to treat neuropathic pain. And this is the SES NICE guidelines that it's the very respectable UK agency that drives and conducts most of continental Europe, that has actually stated that neuropathic pain, patients with neuropathic pain are eligible for spinal cord stimulation in clinical routine, assuming the severity of pain is more than 5/10 visual analog scale, it's chronic, then more than 6 months of pain. These patients should be assessed by an experienced multidisciplinary team, and they should all have a successful trial stimulation, and I'll come back to that shortly. Although there is evidence, and I will show you just one slide about the evidence on ischemic pain, the strength of the evidence is not sufficient as it is to recommend it for routine clinical work in vascular ischemic problem. Now, we all lived, when spinal stimulation came on, we all lived with a very strong dogma. If here you have in red the area of pain, well, in order to have proper pain relief, you should, with the paresthesia you do elicit when you stimulate those electrodes, you should actually cover the area of the pain. As you can see in this patient, you are going to miss the lower back here. And the idea was that if you don't get any paresthesia, you won't get any pain relief. Now, there were a number of other assumptions or dogma that we have lived with, one of which is that sub-perception threshold, in other words, a stimulation whereby you don't feel any paresthesia, can be effective. And it has been shown that with conventional stimulation, you do have in neuropathic patients, here is a study from Volter and colleague published in 2012, they showed that stimulation just below the threshold, so the patient don't feel anything, does have a measurable effect. The other thing is, we thought that you should necessarily link paresthesia to perception. Now, this has also been shown as being not true. And one example, and this is the only one I'll show you, is in vascular pain. You do have, here is a thermography that's taken 5, 8, 20 minutes after the start, either with suprathreshold stimulation, which you see here in the foot, or subthreshold stimulation. And you see that in both cases, you do have an effect. Furthermore, you don't necessarily have to cover all the area that is targeted with paresthesia if you want to have a vascular effect. Now, paresthesia-free, I don't want to bother you with too many technical details, but if you're interested, if you're going to read about spinal cord stimulation, you'll read a lot about paresthesia-free stimulation. Now, you can achieve paresthesia-free stimulation in many ways. And these are subthreshold stimulation, what is called high density. I'm not going to go into that. High frequency that are far beyond the response rate of normal nerve, or burst stimulation. Now, all those stimulation have shown efficacy that was either similar, better, or worse than conventional stimulation. But this variable effect depends a lot on the type of pain, but on the sponsoring manufacturer. And there is a very fierce competition in the area now, which makes it very difficult sometimes to distinguish the truth from the advertising. Here is a very early study, and it's an elegant study considering it's been published in 1996. They had 10 patients unresponsive to conventional therapy. 6 of those patients had type 2 diabetes. They had type 2 diabetes for a long term with neuropathy that was severe, disabling in most of the cases. They did a trial stimulation. They cross over blinded stimulation. So patients were tested during 4 days, 2 days where the stimulation was on and 2 days was off. If the trial proved positive, in other words, if you do get more than 50% pain relief, patients were implanted. And what they show here, that you have a decreased peak pain, both at 3 and 6 months. I've just put in those arrows here to show you that whatever groups you're considering, the difference is statistically significant. Now, it is also statistically significant if you consider background pain, not only peak pain, but background pain. So you see that stimulation really has a not only long-lasting, but also very statistically significant effect, but it's also clinically significant. The other thing that they have shown in 8 patients that responded, so positive trials, they could study 6. 2 of those either died or had a late failure. They looked at the exercise threshold on treadmill, and they showed that at 3 and 6 months, those patients with stimulation actually improved. Now, I'm just going to show you as an example. This is here. We did a study with Rod Taylor, and we showed in 2006 with the 2 studies in CRPS that indeed there was a positive trend towards stimulation. But these were not objective measures, these were questionnaires. A few years back, we did a study in patients with accelerometers. These small devices here have been put on 3 locations on the body: thorax, the abdomen, and the shaft. And they would measure posture, sitting, standing, lying, and walking. They also would allow you to calculate the gait, the angle, the velocity, the distance patients were covering. So you see here, as it was in the previous study, patients increased their walking distance substantially. This is a 450% increase in distance. Now, you have to be careful because 450% increase of virtually nothing is still not very much. So this is a percentage increase, but in a lot of cases, it did actually provide a significant change in the quality of life. Time spent standing and walking increased as well, and that again was significant. And the time they were spent lying also decreased. Of course, the pain score decreased significantly. What's interesting as well is that if you look at the stride length and the speed, both increased, while the variability in stride length and speed actually decreased, which means that overall stimulation, and this was done in patients with neuropathy that were not specifically diabetic polyneuropathy, but it's a strong suggestion that stimulation not only improves the walking and the functional performance, but also it increases the safety of walking. Now, another early study published in 2005 by Dowsey and colleague, they looked at 10 patients, 8 were positive trials, 1 late failure, and 2 died from cardiovascular death and other things. They looked at 3.5 and 7.5 years. See, at 3.5 years, this is the VS when the stimulation is off, the background pain, stimulation off. You turn it on and you see the decrease in pain. If you look at the peak pain, you have a similar view. And this is 3.3 years later. Admittedly, it's a small number of patients, but nevertheless, there is a very sustained response. If you look at 7.5 years later, that is background pain. Stimulation is off here. Turn it on, and the intensity of the pain decreases. Background, and this is peak. And although it has decreased, the improvement has decreased a little bit, it is of the same order of magnitude. And 2 patients at 7.5 years were without medication. Now, here is the first prospective study that was done by a Dutch group. Rachel Slangen, I know, is in the assistance, and good evening, Rachel. She has published a number of the very important data that we have on painful diabetic neuropathy with spinal cord stimulation. Here are 15 patients, 11 responders. Now, this is a slightly lower response rate that we would expect today, and this has an impact on the cost of the therapy. I'll come back to that in a short time. But what the study essentially showed, that you would decrease, stimulation would decrease the pain data in daytime or at night. And the blue line is the intention to treat. So intention to treat will cover some of the patients that were allocated to spinal cord stimulation but never had the stimulation, as opposed to the received treatment. But as you can see, in both groups, the difference is statistically very significant and clinically relevant, of course. They looked at what happened on 3 years later, and you see that pain relief was maintained. That's daytime pain relief, and the quality of life was increased and stayed increased as well in average. Now, there are essentially two major studies in spinal cord stimulation with diabetic polyneuropathy. And this is one of the first, Rachel Slangen again. Oops, sorry. It's a two-center study, 3-to-2 randomization ratio. And again, you see, with a slightly low trial to implant ratio. And the success criteria, which was the same as the one I'll show you in a second, was a decrease of pain of 50%, day or night, and a patient global impression of change of at least very much improved for pain and sleep at 6 months. And you see, if you look at the treatment analysis, intention to treat analysis, spinal cord stimulation patients succeeded in nearly 60%, against only 7% for the best medical treatment, which is what you see here on the right-hand side. The second study was by Cécile de Vos and the group in Denmark, I think. That was a randomized multi-center, 7-center trial, a parallel design, and they had a trial to implant of 92.5%, which is much closer to what we will see today. The intention to treat analysis showed that pain relief was obtained in 13 patients, pain relief more than 50% in 25%. Quality of life improved and the pain medication decreased. Here is the column a bit on the other way. The black ones are spinal cord stimulation, the controls are the light gray ones. And again, you see that the difference is quite significant. Now, this is a study that has not been published yet, but it is available on the preview of a neuromodulation. It's a systematic review and meta-analysis of the neuromodulation treatment for diabetic neuropathy, and that takes into account all modes of treatments. I want to point out that, see, burst, so conventional study is by far the largest group of patients that have been investigated. Now, all the other ones are very anecdotal, and there is not even enough data yet to conclude about the efficacy of those new mode of stimulation. What this meta-analysis showed that overall, you see the pain actually decreased. Here is the 95% confidence interval. And again, we have follow-up, although a small number of patients, but up to 60 plus years, 60 plus months. And the study actually has concentrated on the only two prospective randomized controlled trials that are available, which is the Vos and Slangen. And if you look at the mean difference, it clearly favors spinal cord stimulation. The problem is that over time, you actually do lose some patients. Now, there's a trial, a paper published here looking exactly at that. So from two prospective trial cohorts, 48 patients, some of those have already been presented. What this study essentially showed is that there's a loss of efficacy over time, but this is predominantly in patients who have higher diabetic neuropathy score. And this is related to the progression of the disease, whereby there is an increased large A beta fibrous dysfunction. There was no association between the baseline characteristics and the spinal cord success rate. And the long-term success rate failure was actually associated with the severity of the baseline neural dysfunction. But overall, you see that even though the proportion of patients who do benefit clearly decreases a little bit of time because you lose patients, there is a maintained benefit as far as pain is concerned. And the interesting thing is, if you look at patients who do carry a stimulator, 80% of those are still using their device after 5 years. And even though they may not have what was usually considered a successful trial, they're still using it. One of the big questions, I suppose, is interesting. Most of you who are diabetologists, is how good is this treatment to try and improve the insulin requirement? Now, there's one paper, it's actually a case report, that has showed a rather impressive drop in insulin use, daily insulin use. But I'm afraid this is really the only paper that's out there. It was based on another paper which showed that physical exercise, electrical stimulation, assisted cycling in patients with spinal cord injury had actually improved the glucose tolerance. And I suppose that if you control pain, you decrease stress, and therefore you might be able to deliver a better glucose tolerance. But this, again, remains a very isolated observation. And to my knowledge, there's no series or randomized controls trial that has confirmed this. Now, selecting the patients for the treatment is the most difficult task. You need a clear diagnostic, but this is not specifically for diabetes. This is true for all neuropathic pain. Insufficient response to conservative therapy, that's an easy one. No significant unmanaged psychological issues, no serious substance dependence or abuse, surgical intervention not indicated, and a successful trial. Now, I want to draw your attention on a paper that Sam and colleagues are going to publish in Pain. It's in the preview section now, where they show that this is neither predictive nor cost-effective. And this is a very interesting paper. I think you may want to look at that, although we are dependent on insurance and non-scientific decisions for the use of that in the rest of Europe. Now, what do we mean by no significant unmanaged psychological issues? Well, this is just for you to show. Those of you who are interested, here is an appropriate referral selection pathways that's been published by Simon Thompson and colleagues in the Journal of Pain, European Journal of Pain, and there is a website you can go through, and they'll guide you through the criteria. Now, psychological evaluation is probably a bit more difficult than this. However, as early as '96, Rick North published a paper suggesting that there was little evidence for selecting patients for spinal cord stimulation on the basis of psychological testing alone. Here is a slide that I like very much that I can show you, it coaches you to Dr. Raymond Chadwick, who's a clinical psychologist in Middlesbrough. What this shows is if you are looking for the ideal patient that would fit in the ideal target, then you're wasting your time. This is simply not going to work. And in that sense, psychological assessment is not something that on that basis alone will help you select patients. What will be shown that virtually all patients may go through, independently of what they are, who they are, and what their problem is, with some exceptions. So you'll end up with three ways of decision. Either go ahead, proceed with the treatment, that's a green light. Or most commonly, it's a yellow light. You can say, okay, proceed with the treatment, but psychological sessions pre and post intervention will be needed. Rarely, the psychologist will tell you, well, we don't think invasive treatment is a good idea. Don't do that. Now, there are two questions remaining. First is, how much cost effective is that? Now, there's only one paper, and here again it's a work from Rachel Slungen, and I don't want to go into the details of that. Sam will show you a few slides at the end of the session on ICER. But what this shows is that overall, on the basis of the data we have today, spinal cord stimulation is not cost effective at 12 months. So the cost per quality is nearly 100,000 euros, which is more than 3 times more than what most public health services would be willing to pay in Europe. Having said that, the cost effectiveness is very sensitive to the baseline cost and the depreciation of the spinal cord implant value. So in order to improve your ICER, you either decrease, you have a higher trial to implant ratio. So the more patients you do trial that do respond, the lower your ICER will be. And that means that you have to improve your patient selection. And probably this is very much linked to, the specialized centers and the experience. Now, the lifespan of the battery is very important as well. Rechargeable technology may completely change the way we look at the cost effectiveness of spinal cord stimulation in diabetic polyneuropathy. Finally, hardware, the complication from this technique. Now, overall, the complications are not rare, but they are fairly minor. Most commonly, you have migration. In the early days, migrations were a big problem. Today, with the multiple electrodes per array, we can usually reprogram without having to re-intervene surgically. Fractures have been a problem, are less of a problem today, and battery failure are in the order of 2%. The biological complication, the implant site related pain can be rather high. A third of the patient will complain on pain in the area of the implant. Now, the vast majority, more than 80%, will have occasionally a mild pain, but up to 10% will still say that's bothering. An interesting study that was a large retrospective study actually suggested that diabetes, obesity, or smoking history was actually not a factor of infection, which still occurs between 2 and 3% in the recent study. Gain was much higher earlier. And there are therapy-related complications, dural puncture, neurological injuries. Now, this can occur, but it appears that it has occurred mostly with one technique, which is DRG stimulation, which is a technique that has been put on hold in Denmark, and this is published in Neuromodulation. So in conclusion, spinal cord stimulation, compared to the best medical treatment, provides a statistically significant and clinically meaningful, this is important, pain relief at day, night, and at long term as well. The evidence for day and night pain is level 1. There's only level 4 for the long term because of the small number of patients. It does improve the quality of life and has still an unproven cost effectiveness. Again, I don't think we can rely on the cost effectiveness of the treatment we have today because the technology has actually changed. Complication, as I said before, can be up to 40% of the cases, but more commonly hardware than biological. No serious or damage neurological complications have occurred with straightforward techniques. So in conclusion, spinal cord stimulation is safe, effective, and above all, it is reversible. And with that, I'll leave you with a view of some of the mountains. Here is the Matterhorn, with some snow residue, which I've seen last weekend. Thanks very much.
Thank you very much, Professor Buscher, for this wonderful talk and sharing with us the new data regarding the spinal cord stimulation and telling us that it is one of the useful techniques in people who are having an irretrievable painful neuropathy. So for the last session of the day, which is a case discussion, clinical case discussion, I will invite Professor Sam Al-Dawi to proceed the case. Professor Sam.
Thank you very much, Dr. Mian. I will present a case, one of my patients, and I will also talk you through the technique, and that may help make you a little bit more familiar with what we do and what are the steps, etc. To start with, the spinal cord stimulation in painful diabetic neuropathy, as you've heard from Eric's lecture, the experience in this particular field, when you think about the number of people out there with painful diabetic neuropathy, you find that our experience is very limited. Indeed, the research, you've seen the numbers are limited. Yes, the device research carries much smaller numbers than what you would expect from pharma research, but there are other reasons for why this is an issue. Largely, it is a perception on the part of the people who refer this, diabetologists, is if I refer my patient to the pain clinic, what will happen? They will get the same, they will get more drugs. And I know exactly what the guidance is for painful diabetic neuropathy, and I have no doubt that you know this better than me. and that there are no other options apart from something like these the neuropathy tablets that you can see on the right side. It's not necessarily the case. Indeed, we did prescribe quite a lot of medication in pain clinics in the past, but the trend is now moving away from prescription of opioids, gabapentinoids, and indeed most medication prescribing is coming out of fashion, if you like, particularly for long-term pain. But we have several options in neurostimulation, and there are many emerging technologies. So let me just talk to you about my patient. My patient is a gentleman who came to see me about, I think, 3 and a bit years ago. He's a 66-year-old man. He was actually used to work in a circus. He was an acrobat in a circus and had done this all his life, and then developed diabetes at age 50 and had to retire. He had a 5-year history of bilateral painful diabetic neuropathy and was what you would call a very miserable man. He was quite clear in describing what his symptoms were, and basically I got this photograph that describes exactly what he told me. He says, I'm walking on needles all the time, and his symptoms were mostly in his feet. He had very little other symptoms than in the sole of his feet. He had, of course, tried SNRIs, anticonvulsants, antidepressants, and was largely intolerant of opioids, which was his luck. Before I take you any further about the story of this man, I will just show you a bit of what we did. So there he is. You can see the picture on the left-hand side is him lying on the operating table. What you can see is his back, particularly his thoracic spine and the higher part of the lumbar spine. And you can see here I've marked the thoracic spines with these horizontal lines, and we've infiltrated some local anesthetic. So the technique of spinal cord stimulation is largely done under local anesthetic. And here, under local anesthetic, we've inserted a needle into the epidural space. You locate the epidural space just by injecting some saline. Because of the negative pressure, it is easily located with loss of resistance, because it has like a suction effect, the epidural space has. And there you are, needle in the epidural space. You can see that the puncture is, here is thoracic vertebra number 12, here is lumbar 1, and the needle is entering below L1, so in the epidural space of L1. And here you can see 2 wires. We've inserted another needle and put 2 wires in the epidural space. Now, these wires are not advanced haphazardly, they're advanced under X-ray, and they advance to a particular position to produce sensation in the soles of the feet. And I'll show you the X-rays of these wires in a minute. But as Eric mentioned, the idea that these wires, when connected to an external stimulator, which you can see in the corner of the picture there, will convey current to the spinal cord, and that current will produce a pleasant sensation of pins and needles in the user in a particular area of their body. So if I took that wire up to their neck, they would feel the pins and needles in their hands. If I took it down to L1 or T12 or T9, they would feel it down in their feet. And that's basically the principle of conventional stimulation. Now, you can stop at this stage, take the needles out, and you have what we call a trial of spinal cord stimulation. So a pair of wires connected to an external battery, and you can send the patient home and say, you try this and tell me whether it works or not for your pain. And we used to do that routinely for everybody. We no longer do. You can otherwise open up a small incision. This is a very magnified picture, and it looks like a very deep and very large wound. This is a 2-centimeter wound, and this is just subcutaneous tissue. And what we're doing is fixing that wire to the subcutaneous, to the fascia, which you can see down there. So you open up, fix the wire to the fascia so that it doesn't migrate up and down the spinal canal. And then you can, the next job is to attach it to a battery. The battery, or what we call the pulse generator, is what produces the current, and that's the bit that is implanted inside the patient. And here you can see wire tunneled and under the skin and attached to a battery, and there it is, job done. So this is the technique of spinal cord stimulation. You can do an external thing, as we said here, which is a trial. So you send the patients with these wires, needles taken out with and an external battery, or you can implant the whole lot with an implantable battery. Now, is this something that requires admission? No, the majority of these are day case surgery. The battery goes in the subcutaneous tissues of the buttock or the abdomen or the chest wall. Most patients are recovered enough within 3 to 7 days. The implant itself, the battery, is controlled by a handheld controller that the patient puts over the device or away from the device. Nowadays, it's all Bluetooth. And they control the device. They can switch it on, they can switch it off, or they can turn it up and down in intensity of the current through these buttons here. As you've heard from Eric, there are an array of these devices on the market, and the battery life, which determines the cost, varies between 4 and some companies say 25 years. But let's call it 15 years is more realistic. So what happened to my client, Mr. NB, the circus acrobat? Here you can see the wires under X-ray, and you can see the position of the wires and why this position is quite important, because the spinal cord dorsal area has a somatotopy where the body is representative in the spinal cord, as you have the same representation in the brain, in the sensory cortex, and it's not very different here. So this is the area around T9, 10, and 11 where you will get stimulation of both feet, and you will get this with wires in the midline. You can see in the lateral X-ray, the wires need to be in the dorsal part of the spinal canal. Here is the spinal canal, and the wires need to be in the dorsal, not in the ventral part of the spinal canal, where they would stimulate motor fibers rather than sensory fibers. So our client, how did he do? He had a pain score of 8 out of 10 before his implant. In the UK, we routinely measure quality of life as opposed to anything else in the pain clinic because it gives us a global idea of how the patient's doing. And we're finding quality of life much more important measure than just the pain score. The EQ5D is a simple one-page measure of quality of life that measures your health-related quality of life along a scale from 0 to 1, with 0 being a quality of life so bad as it is equivalent to death, and 1 being perfect quality of life. So as you can see, this gentleman here had a very, very low quality of life. He's near enough to 0, 0.157. That is despite taking a very large dose of gabapentin. At 6 months follow-up after he was implanted with the device, you can see the pain score came down significantly to 3 out of 10. But more importantly, his quality of life went up from 0.15 to almost 0.7, which is quite a remarkable increase in quality of life. But why are we bothered about this EQ5D? We're bothered about it because that's how our funders, the insurance, the national insurance, and the NICE, the National Institute of Health and Care Excellence, decide whether what you're doing is worth it or not, whether it's cost effective or not. And it is that difference that drives whether an intervention is cost effectiveness, the quality of life after from the quality of life before. I've been able to look up this gentleman's 3-year follow-up data quite this morning, and his pain score at 3 years is a little bit higher than what it was at 6 months, which is fair enough. People get used to pain intervention, and pain scores are very subjective, and this is not he was not the happiest of customers on day one. But more importantly, looking at his quality of life, which gives you a global assessment of pain, mood, function, and self-care, you find that his quality of life remains very reasonable. As a matter of fact, the UK normal on an EQ5D is 0.8. So this gentleman is not very far off normal, despite his diabetic neuropathy and his ongoing diabetes. More importantly, he's not taking any more gabapentinoids or opioids. And asked about his satisfaction with the treatment, he remains very satisfied on a global perceived effect scale. So just talking a little bit about these devices, before I tell you how much these devices cost, I'll just introduce you to the incremental cost effectiveness ratio, or the ICER. But basically, we look at the cost of a new technology, like spinal cord stimulation, minus the cost of what would the patient have had otherwise, and that would include gabapentinoids, SNRIs, and all the adverse events and the care necessary because of falls, etc. Then you look at the outcome, which is the EQ5D on the new technology, minus the EQ5D that he had when he was on usual care. And that allows us to calculate a figure called the ICER. In the UK, if this figure is above 20,000 pounds sterling, then it is not worth it. If it is below 20,000 pounds sterling, then the National Health Service pays for it. So let's talk a little bit about the cost of these devices. The devices cost between 9,000 to 20,000 pounds per patient, so they're not really cheap. But when you think about it, if you're paying 20,000 for a therapy duration of 15 to 20 years, that's £1,000 per year, and that's not particularly expensive. The difficulty with these devices is the bulk of the cost comes up front. As Eric told you, some of these devices come now with rechargeable batteries, and you can see how a patient charges the charging head from the wall, puts the battery on their skin and recharge their battery, and that would keep that battery going for a number of years, up to, as I said, companies claim 25 years, but 15 years is something I have seen. The National Institute of Health and Clinical Excellence did a cost per QALY analysis. A QALY is a quality adjusted life year, if you're not familiar with that speak. So how many quality years have we added to that patient's life because of that intervention? And in patients with neuropathic pain after back surgery, they found that the figure of this cost per QALY is £9,000 if you compare it to a medical management, and if you compare it to surgery, it would be £8,000, and they're willing to pay, as I said, up to £20,000. So from our point of view in the UK, for neuropathic pain, these devices are cost effective. Globally, this is a global assessment on neuropathic pain rather than a specific assessment on diabetic neuropathy. I think that's all I have to tell you today, and I will say thank you very much, and hope to speak with you soon. I think if I may stop sharing and ask if Eric, do you have a case you want to share? I think we've been
Yep.
Yeah, please.
Very shortly.
I think the issue is we We had late apologies from Dr. Al-Hamdi, so we had very little time to prepare for these case presentations.
All right, I just wanted to show you, and again, this is very last minute to put together case of the first case that came to my mind. This is a 50-year-old gentleman from Turkey. He is very disabled by this neuropathic pain he has in both legs and feet, and he's actually unable to work. He had diabetes type 1 for more than 10 years, has a renal impairment that's pretty severe, to the extent that the NSAIDs are cannot be used at all, and he has a painful diabetic neuropathy for at least 3 years. The DN4, which is the grading of the importance of neuropathy, is at 5 over 10 of a maximum. He has foot sole allodynia, decreased cold sensitivity, increased response to pinprick, and slightly decreased paresthesia. Now, this is the distribution of pain. And here is what happened over time. We just have a 1-year follow-up for this patient now. So you see, the VAS score was 8.9 at baseline. And the way we do it in my center is we do trial patients on an outpatient basis for 3 weeks. So first thing I want you to see is that the pain did decrease, but slowly. We did implant with a score of 8.1, and it took 3 weeks to decrease to something, to a level where we would be satisfied and convinced, although the patient was convinced. So he was implanted. Here are just the electrodes and where they have been implanted. This is T12, 11, 9, as Sam told you, we should be able to target this area if we want to get paresthesia in the feet. Now, the interesting thing is that this pain score did not drop dramatically. It remained rather high, but pain at night was decreased more than during the day, and that was very important for the patient. The sleep was much improved, and despite the relatively high pain score, the patient's satisfaction remains very high. The medication overall has not changed very much, although he's not taking any opiates anymore. So the lesson from this patient is both that if you have neuropathic pain, at least in my experience, you have to wait for a few weeks until you see a significant effect. Short-term evaluation of spinal cord stimulation in neuropathic pain is often very difficult. And then, even though the scores do not go down to very demonstrable level of 1 or 2, patients still are very satisfied, because not only pain is a problem, but their sleep, the pain at night, their mood, their quality of life, and the medication may change to the extent that they are happy with or more happy than what they had before with the medication. And this is what I wanted to show you, Jerry.
So we have a number of questions, and the first question is for the Professor Hasnan: does improving glycemia improve DPN?
Well, as I mentioned, good glycemic control can prevent it happening, but once it's there, the change in glycemic control doesn't not change the level of pain. In fact, sudden drop in HbA1c can sometimes trigger painful neuropathy.
And the question for the Sam Is the peripheral neuropathy has some central connection as well?
I think that most neuropathies have to have a central connection to maintain the pain, and the central sensitization is what we call it, occurs with continuous peripheral firing, and that occurs at the level of the dorsal horn of the spinal cord. So the fact that you have continuous painful signals entering the dorsal horn of the spinal cord results over time in facilitation of the transmission of these signals, and you therefore get more facilitation of pain upwards into the brain, and that creates a reduction of the descending inhibition. And all of this results in maintenance of that particular neuropathic pain.
The question again for Professor Hasnain: how can we titrate the dose of these medicine, keeping in mind the side effect profile of all these medication?
Yes, it's not that easy. We face a number of side effects with some of our patients, but normally with pregabalin we start with a low dose twice daily, and then we increase it, we double it over a scale of 2 to 3 weeks, depending on how severe the pain was to start with. So 75 milligrams moving up to 150 milligrams BD, and sometimes you have to go up to 300 milligrams twice daily. That's the usual. For diloxatine, although it doesn't give the side effects of the drowsiness and the sleepiness, but many of our diabetics are obese and they have a grade of hiatus hernia and acid reflux. And unfortunately, that sometimes is a limiting factor, although the drug is quite helpful for those who can tolerate it. So choosing between which one is best for them is sometimes a tricky option, trying one and then switching to the other. I don't know whether Eric and Sam have their input on the combination of both, of antidepressants or two anticonvulsants.
Yes, I think we do use combinations in people who fail to respond to one drug. I find the combination of gabapentin or pregabalin with diloxatine very difficult to manage because the side effects are very similar, but a combination of diloxatine with a tricyclic perhaps is easier from my point of view because it improves. You can give a very small dose of tricyclic, like 10 milligrams of amitriptyline at night, to improve sleep and rely on diloxatine throughout the day. The problem is that tricyclics have contraindications in cardiac disease, in prostatic problems, eye problems. So it isn't that easy to find a patient with diabetes comorbidities who is actually eligible for a treatment with tricyclic. Eric, do you have any thoughts?
No, I don't have anything much to add to that. My experience is very similar to Sam's, and I do find that patients very often have difficulty in sleeping. So amitriptyline is something that is certainly helping. Now, although I know that there are cardiac contraindication and other type of contraindication, I believe that if you stick to the very low doses, this may not be as important or relevant that it may be with higher doses. And the other thing is that when you look at those patients, your goal is to improve the patient's quality of life and pain. So a lot of my patients with spinal cord stimulation still do take some of those medication, and there's nothing wrong with that as long as they don't have the significant side effects. So I believe that a combination of spinal cord stimulation and one or two anti-pain drug is actually quite reasonable over the long term.
So one question is the spinal cord stimulation is a dream therapy in a poor countries. So what is the cost of this and how, although you have already mentioned in your talk, this is a question for Sam. So how cost effective is this, and who are the right candidate for this one?
Well, if you like, I'll answer the question about cost, and I'll hand over the right candidates to Eric, because he covered that. So the costs of devices varies greatly between rechargeable and non-rechargeable devices. So if you're looking at a primary cell battery, which is going to be explanted its end of life, these are largely about 9,000 British pounds. Rechargeable devices can last for much longer and cost a lot more, so they will go up to about £20,000 per patient. Having said that, you are getting almost 20 years of therapy, so compared to the cost of taking Pentanoids for 20 years, you'll end up with something that is not far off the cost of a stimulator. The problem is whether the healthcare system can afford to pay for this upfront.
Okay, so can the gabapentin and the antidepressant be used together in not responding cases with one drug, with combination of the drug?
Yes, I would say you can do that. You can combine gabapentinoids with antidepressants. However, the fact that both result in very similar side effects is quite a difficult one, because usually the drowsiness that amitriptyline or nortriptyline causes, or the oversedation that it causes overnight, usually reinforces the dizziness that you will encounter because of gabapentin or pregabalin. That's generally the complaint that stops most people from taking either class. But yes, the combination is a possible one, but in my experience, difficult.
Okay, so this is a question for the Eric. Who are the right candidate for this spinal cord stimulation?
Well, the right candidates are basically patients who do not respond to the best conservative treatment and associated procedure that you can suggest. Now, for diabetic polyneuropathy, there is obviously no intervention in terms of surgery or other procedure that comes into mind. So I believe that if you do have a patient with unrelieved severe pain, by severe I mean VAS over 5, with treatment that have been ineffective or not well tolerated, I think that in the absence of marked psychological problems, a trial is justified. Now again, the success of a trial in a study will be well defined. Now you may have patients who will not reach those targets and will say, okay, my pain has decreased 40%, but I sleep better. But there's nothing I had before that was as good as that. My pain at night is much lower. My quality of life has increased. So there's a number of factors that should be considered before you go ahead with the treatment.
Okay, this is the question for Sam as well. I think the if the diabetic patient develop dependency to pregabalin, how it should be dealt with, and what are the better alternative for this?
I think a very interesting question. Thank you. From my experience in reading of the literature, an isolated dependency on pregabalin has been recorded. It is possible, but it is not very common. Most people who take pregabalin as a drug of addiction take it on top of opioids in order to either temper the effects of opioids or temper the withdrawal effects of coming off opioids. The combination of both drugs, so if you have somebody who you suspect is addicted to gabapentin, then you need to think to yourself or ask the question, what else are they taking? Because in a lot of cases, you might find that they are taking either legal or illegal opioids, and the evidence shows that the accidental and overdoses of both drugs are much more lethal in this group of people who take both drugs than taking either alone.
Okay, this is the one of the interesting question. Is there any drug that can heal and repair the TPN rather than just to treat the pain? So, anyone?
I'm not aware of any drug that, as we mentioned, all the guidelines are saying the drug are to control pain and improve quality of life. We don't have something that reverses painful neuropathy.
Yeah. Well, we are waiting for this wonderful drug then. Yeah.
Yeah.
So few more questions, I think, or let's see. So this is the regarding. I think the can spinal cord stimulation help in people with autonomic neuropathy? This is out of question, but still.
Well, I think that there are data that have showed that spinal cord stimulation can modify the bowel activity and therefore influence, and that is through obviously the autonomic system, and that is true for the bladder control as well. So the answer is yes, it can. Now, to what extent is the control of autonomic nervous system crucial to the success of spinal cord stimulation for pain? This is, I think, an open question. There is experimental data to show that if you do a sympathectomy in animals, the effectiveness of spinal cord stimulation actually decreases in the area of the sympathectomy. But whether this is translatable to humans, I do not know. But I think there is a fair amount of evidence that yes, we can modify the autonomic system by stimulating the spinal cord.
And there is an interesting one, another. Is there any improvement in neuropathic pain with implantation of in a spinal cord injury patient?
Yes, I mean, we have just finished the study on, it's a small pilot on 10 patients that we followed up for 2 years. And yes, there is an improvement in the nerve pain of spinal injuries. We haven't been able to show any improvement in function, but we can see a great deal of improvement in pain reports and in some of the sensory manifestations.
Yeah, and talk about patients with spinal cord injury. I think these are the groups where it has been shown that spinal cord stimulation does modify autonomic nervous system, for sure.
does it, the spinal cord stimulation helps in the nociceptive pain as well, or it works for the neuropathic pain?
Well, I think the evidence today is clearly that it does not control nociceptive pain. I think it's an open question, and this is something that has been, suggested and pushed by some companies. But I do not believe that we today do have any kind of credible indication that spinal cord stimulation does control nociceptive pain.
Okay, great. So I think we covered all the relevant question, and it's looked like we have done with the question, and I must say it was a great webinar, and the participant learned more about the new techniques in the painful neuropathy, and especially the endocrinologist who deal with, and the internists who deal with day in, day out the painful neuropathy, and they stuck with this 30% or 50% pain relief, can now think about this something else, and we can give our patient some different thoughts, and we can help them more with this spinal cord stimulation. Thank you very much, Professor Hasnan, Professor Sam, and Professor Busher, and I think everyone. I will say thank you to the participant as well. We have quite a number of participants today, and just to remind you that please fill in the feedback form in order to get certificate for all attendees. Doctor from the participant from the Saudi Arabia can get the CME within 3 days, and the participant from the GCC countries can get the certificate within the 14 days. With this, I thank you all for participating in this program. Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you.
Bye.
Thank you. Good night.